quarterly Define our series. I know folks will continue to hop on, but for being respectful of everyone's time, it's really my pleasure to introduce and welcome Dr. Lori Sherlock as our Define webinar speaker today. Lori is an assistant professor of pediatrics here at the University of Colorado School of Medicine. She's also a neonatologist here at the Anschutz Medical Campus. Lori's portfolio is quite broad, ranging from basic science research focused on selenium supplementation and metabolism, and through all the way to how we can better engage with families and importantly, ensure that they are seen and heard and supported during the prolonged NICU hospitalization that their family endures. With that, I will pass it to Lori. I will be monitoring the chat, so feel free to chat in questions, and we'll have time at the end of Lori's presentation to get to these questions. Thank you again so much. Lori, over to you.
Thank you so much, Susan. And I'm really happy to share a little bit of what I've learned and thought about communication. Really, just before starting, I feel thankful. I'm currently at a conference that is really focused a lot on people who are helpers, maybe who hope to be healers or even transformers in their spaces. And in some of my morning sessions, I was thinking about this defined group and that all of you are helpers, maybe healers, likely hoping to transform some of the spaces you're in. And this morning, we've really kind of discussed and processed that right now things feel hard and that sometimes we have the capability to move through that well, and other times it's a little bit stickier, but that we do it better as a group. So if any of you are in a space where it feels hard right now, I hope this hour you're reminded of this community that we're in. And this is an informal talk. People can ask questions as I go. I'm probably mainly going to be saying things people already know. But for me, a lot of times communication, there are tools that I've been taught and use a lot, tools that I've been taught and forget to use. So I hope there's something for you in this chat. My goals and objectives are to identify why communication is important yet challenging, to talk about some evidence-based tools and review some scaffolding to support you, to support all of us. I imagine all of us see the value in effective and meaningful communication. And just to highlight some of the ways communication is evidence-based to impact the medical space we work in. Highly effective communicators can lead to shortened time to diagnosis or treatment, improved diagnostic accuracy, increased therapeutic compliance, more cost-effective care, and decreased litigation risk. Perhaps the other ways communication is demonstrated to benefit are ones that I really resonate and aim to move towards. Those include patients having increased in reported trust for their healthcare team, improved patient satisfaction, psychologic benefit to the patient, including decreased emotional distress, and interestingly, and I think importantly, a psychologic benefit for the provider. Many of us went into this job wanting to help, and effective communication can help us feel like we're doing our jobs well, which can keep us in this service-driven work longer. It has been shown that after communication training, many providers have decreased burnout, including decreased depersonalization and decreased exhaustion, and an increased sense of accomplishment, as well as improved work satisfaction for the provider. So when I think about communication, I see huge benefits to both sides of the provider-patient interaction that could potentially help the wellness in the entire system. In the NICU, communication is, to me, even more important because many of our patients will go on to become children with chronic critical illness. Many of our patients go home and stay home, and another set are babies and children who go home and then repeatedly have rehospitalizations, sometimes multiple in a year, sometimes multiple through their childhood. We know this is an increasing percentage of our NICU graduates as we're keeping alive babies with more and more complex care. And this also makes up a large portion of the pediatric freestanding hospitals among us. They're these children with chronic critical illness. When you think about the caregivers and parents for children who have pediatric chronic critical illness, there's a higher incidence of major depressive disorder. Some studies show 40% compared to a baseline 10 to 12%. PTSD, a third to half compared to 3 to 4% of the general population. Increased anxiety, about half compared to 8 to 20% of the general population. And then increased isolation, medical trauma, caregiver burnout, and frequently a need for one parent to decrease their work hours or stop working. So this is a group of parents who are pouring out their hearts and souls to their children and have a high incidence of increased needs themselves. So communication is important, yet it's also challenging. Even when we walk into the room wanting to do a great job communicating, it is sometimes hard to get that done. And I think some of that's because of variability in how individuals like to give and receive information. So finding that match can take a little bit more work. Additionally, communication is hard because of many obstacles in the way. And I think about obstacles on the family side and obstacles on the provider side. I've put these up here as reminders that on both sides of the communication and the dialogue, there can be sticking points or feelings or things that can obscure what we're really trying to say or how we hear it. Uncertainty, guilt, fear, hope, trauma, and then mismatch of language or literacy are, in my mind, some of our most common barriers. I like reminding myself these categories so that if I'm in a dynamic and I sense communication is not as effective as I hope it to be, I'm able to pause and ask myself, could any of these sentiments or challenges be what is obstructing me from my end goal? Can we make it easier? Yes, I absolutely think we can. So let's talk about that. The first thing I'll emphasize, and again, all of you know this, is that communication goes much better when we put our energy into controlling our controllables and practice letting go of what we don't. So what don't we control, or what do we have imperfect control over? The antenatal environment a child was in, the increased risk of infection that our patients often carry, and the setbacks that these infections can bring. Side effects of many of the treatments to keep babies alive. Past medical or personal trauma for any family members or caregivers. Coping skills of family members and caregivers. The reality of medical care in a NICU with its sometimes chaotic schedule where things are hard to predict. Life that's happening to families outside of the hospital. And then choices and communication when we're not on service or in the hospital. When I pour my energy into these different aspects of care, I become less effective myself and have less energy to give to the parts that I do control. So what do we control? How we get ready for our families, how we prepare ourselves emotionally to work with the team, and how we work together as a multidisciplinary team. How much attention and presence we bring, to individual encounters, and essentially how well we listen and respond to patient-guided questions and emotions. We'll go through each of these in a little more detail. When I think about building unity among our teams to help our patients, I categorize the things we control into kind of big groups. One is preparation. Sometimes the preparation we put into creating a space for a communication to occur is just as important as the communication itself. In terms of how we get ready to care for families, I believe there's great work that we can do to improve our sign-out process at all levels and disciplines, and how we get ready to discuss things with families in terms of our verbal and written communications and notes to each other. I think there could be important and interestingly process improvement in terms of this aspect of communication and care. The next is how we emotionally prepare ourselves to work on the team and talk with families. And this really gets to wellness, well-being, whatever buzzword you're more comfortable with at the moment. For me, taking care of myself is the first step towards being able to take care of my patients and families. I have tried, and I'm sure many of you have tried, to pour out of an empty cup. And after failing at that process many times in a row, I have finally come to accept that's not going to work for me as a human being. So I appreciate efforts that include team wellness as part of them, because I deeply believe it'll help us give better care. And then finally, how we work together as a multidisciplinary team. To me, I love teamwork. I love collaboration. I love camaraderie. This keeps me going when the days are hard. And when there's a highly effective teams, I am positive our families get better care. Some of the ways multidisciplinary teams can come together to improve things at the bedside are special focus teams, so teams of many people working together to help carry the load. The importance of building psychological safety in our workspaces and encouraging many team members to be engaged and speak their perspectives. In terms of another category of things we can control, which I believe are very worthwhile to put our energy into working on, are really how we get ready to sit down with our families. One is how much attention and presence are we able to bring to individual encounters. I think that our presence is one of the best gifts we can give each other and our families. And for me, this is a practice. I have days where I practice this well and days where it's a real trudge to use these skills and to use these muscles well. But having intention around it has really allowed me, I think, to develop this skill. And I will emphasize that wellness and self-care are essential for this, because when I am not well, I cannot be present in a way that helps anybody. And then how we listen and respond to patient-guided questions and emotions is incredibly teachable. There are communication practice and trainings where we can learn skills that will allow us to become more efficient and effective communicators. I've done several communication training experiences in my career, and I can speak from my personal experience that they have been transformative. I think at this point in my career, I am a fairly decent communicator with my families, and some is intention that I want to do a good job, but a lot is that I have a learned skill that has been taught to me that I have practiced. And it is a skill set that is so transmittable, and we could disseminate throughout all of our working spaces to assure that everyone has an ability to connect meaningfully with our patients and families. So I'm going to prove to you all that I am not a sage on the stage. This was my early model of communication. I thought that Lori Sherlock medical student, resident, fellow, even early attending, I thought my job was to give information and answer questions. Those were my goals and objectives. And that is how I would prepare for patient encounters. I'd think about what information do I need to give, and then I would focus on what answers I was giving to questions they had. After communication training and more life experience on my own, I now have a 5-step process. I'm going to walk you through it. You can make it your own. Maybe for you, you want a 6th step. Maybe you want to rename the steps. But my new model is incredibly useful. And what I like about 5 steps is that if I'm very tired, I can use the fingers on my hand to physically help remind me, where am I and where should I go next? Okay, so let's visit each of these steps one by one. These are based on Vital Talk, which is a national platform of empathetic communication skills and tools. The vision is for every seriously ill patient to be surrounded by clinicians who can skillfully discuss what matters and match care to values. I love this framework. I recognize there are other communication training platforms that are also incredibly beneficial. And if you're considering communication training, I would say just start. Get yourself in there, get yourself some tools you're going to try and use, because that's how you'll become the best, the fastest. Vital Talk is evidence-based. I think at this point there are over 50 peer-reviewed publications. These are didactics and sim patient experiences. And it improves communication skills pretty much for every specialty that's been studied, including interprofessional teams. So there are some Vital Talk programs that even look at interpersonal conflict within a medical team, which is pretty cool. It is most consistently shown to improve the comfort delivering difficult news. And second thing, providing a toolbox for responding with empathy. I will caveat that it is a recipe for improved success, but not a Lego kit. And when I say this, what do I really want? Like if I was gonna buy something on how to make my communication better, I would want really clear, reliable instructions. I'd want pieces that always connect, and I'd want a fulfilling result if I put in the work. And that's really not what any communication training modules give you. I think that what is possible and what you get is a simple scaffolding to follow, which is great because it can allow for variable ingredients. These scaffoldings work when there's a variable amount of time that's required for different ingredients to blend. But the piece that's challenging for me to accept emotionally is that sometimes, even when I put in the work with what I think are great quality ingredients, sometimes I'm still not totally satisfied with the end result. And I'm just going to name that because many of us try really hard to do a great job with our families. And it can be easy and tempting when we have patient encounters that don't go how we hope to tell ourselves we were insufficient, or we didn't use the right words, or we messed up in some ways. Now, sometimes there are communication quirks that can allow us to build bridges, even with the most challenging cases and families. But other times, those aspects, those categories of things that obstruct communication, fear, guilt, uncertainty, those things might be in our way, and we may not be satisfied, and that just may be even with best results. So I name that. I hate when I find myself in that situation, and if you are ever in that situation, I strongly encourage a peer-to-peer consult so you can get some emotional support for your work. The two things many of you have heard me say are that the most common ways we waste time communicating are, one, by giving cognitive information when patients are blocked by emotion. And the communication training tool to combat that is to save time and communicate more effectively by dealing with emotions as they come up. So the principle is respond to emotions instead of pushing through transmitting medical information. Many of you in the room are probably incredibly intuitively and experientially skilled at this. And the second way we can waste a lot of time communicating is when we try to guide people blindfolded. We can improve upon this by investing upfront in learning where a patient is at and where they want to go next. So that brings us to our 5-step process, the first of which is assessing where the patient is at. This to me is a curiosity step. It is a step where you're starting to build a connection, and it is worthwhile to invest time on this because it will help you better guide and support the family, and it will make your communication more efficient. It's going to save you time, and likely it is going to make your communication more fulfilling because you're going to connect on a deeper level. We often think that we go into our hospitals or nurseries or spaces we work in, and we want to help guide people through difficult journeys. That's certainly why I came into the healthcare system. But too often, I think that we forget that the people we're guiding may be in a different space than we are. And if we don't know where our families are trying to go, meaning what their patient-centered goals and concerns are, what type of shoes and equipment they have, or what is their health experience and health literacy, how they process directions, as in what is their learning style, what are they carrying on their backs that might make the journey more arduous, past medical trauma or experiences in their lived life, and then the type of endurance that they have or bandwidth. If we don't know these things, we can't match where a family is and effectively guide them. I myself have frequently throughout my career attempted to guide people blindfolded, or to say, I think I know where you should go and I'm going to try to take you there, without investing the time to know if that's where the family wanted to go. So what do I do now? I'm going to give you a script. These are some simple examples, simple ways to practice using words. And you can find different expressions that feel the best in your mouth, that feel the best in your voice. But typically, things like, to make sure we're on the same page, can you share with me what you've heard about your child's medical conditions? Or could you explain to me what you've heard from the rest of the team? I'd like to pick up there. Or have you heard what to expect over the next week? Those are really nice open-ended questions to start. People who have studied how long patients speak versus how long physicians and healthcare providers speak say that it is quite rare for families to speak for longer than 2 to 3 minutes. I suppose when many of us were learning how to take a medical history, I was fearful of asking open-ended questions for fear that time, which feels of the essence in many of our spaces, would just be too much or too long. So I remind you that it is almost always that people will finish up answering open-ended questions in less than 2 to 3 minutes. And in the rare case where they keep going, I can give you a couple of scripts to help redirect. The fourth script I have here is something I do at the start of all of my 2-week blocks, really just asking simply, what are your biggest goals and concerns? And I find that can really illuminate many things to help me get to know a family better. I will add that tell me what you've heard is much more powerful than tell me what you understand. Tell me what you understand carries a little bit of testing of what a family might have understood, as opposed to tell me what you've heard, which puts the onus really on the other healthcare providers. How long, when I'm trying to get to know a family, I rarely spend less than 5 minutes in step 1, and I rarely spend more than 10 minutes. If a family won't talk much, I often use connection bridges, where I almost put aside the medical goals altogether and try to connect as a human being. I imagine many of you in this room are very skillful and already do this. But if I'm running into a wall, feeling like a family doesn't want to talk to me, I just simplify and try to talk human to human. Tell me about your baby's personality. What is your baby like? Are you local? Do you have family nearby? Occasionally, I'll also try, from the prior team, I heard this. Can you tell me what that was like? And sometimes that works. And when families, the rare times when a family won't focus or stop talking, I often use a respect statement, and I'll teach you what that is in just a few slides. And then I do ask a question with a narrower focus once I feel like I've learned open-ended might not be right for this dynamic. But to me, this is the step I spend the most time in. I think it is completely transformed how I'm able to connect with families. I've really just shifted my goals to learning what matters to the family and their baby at that moment. And importantly, I think it helps build trust. And we just have so much mistrust in the healthcare community right now. More and more families seem to be entering our hospitals fearful that we're not there to help them. So for me, every exchange is an opportunity to rewire some of those pathways. So I think it is beneficial no matter what. Something I try to do, and is a practice for me, is to try to mirror language, knowing that that helps improve trust. So if a family starts using a certain expression or set of words, I'll try to jot it down and then reuse those words as my time goes on with that family. The second step is a micro step. It's a really short step, and it's an ask step. It's asking permission if you can share new information. So you've gotten to know the family, they've told you what's important to them. Let's suppose you really have a medical update. Asking, would this be an okay time to talk about the test result? Is this an okay time to share some new information? Is a really small way of trying to level some of the hierarchy. Almost always families say, yes, it is a good time. And if a family says no, for me, I'm asking genuinely. If a family says no, I think that's great. Because if they say no, I almost wasted a lot of my time. I was almost about to jump into a conversation that a family wasn't ready for. If a family says no, often you can pair it with an exploratory question. What would be a better time? Is there anyone else here you'd want with you for us to discuss this? Or is there anything I can do to support you as we work together? I've had some people ask, what about when it's acute? What about when it's life or death and you have to give an update because you need to make a decision around surgery or putting in the breathing tube? I actually think those are situations where less asking. So that's not really a situation where no is an acceptable answer. So in those situations, I would really encourage physicians to focus on a warning shot and giving the information. I'm sorry, but we have to urgently reintubate your baby. This is critical for their health. Okay, on to step 3, which is for me the hardest of the steps, which is providing a clear headline, which is a short, simple transfer of information. A headline is really how we tell a family something new. And it's a short, succinct piece of medical information paired with a meaning. So it would be pairing medical news with really getting into the meaning of how it's going to impact the baby, child, or family. And with this, one of the ways to become more effective at headlines is to skip medical jargon and to just simplify your language. Perhaps early in my career, I thought one of the ways to be trustable to families was to seem knowledgeable and to seem like I had all of the dressings of a fine medical education and could use the words and convince them to trust me with that. But I think that when we really get down to it, people are going to trust you more if they understand what you're saying. So I've moved towards removing as much medical jargon as possible, unless people are asking and using it, in which case I mirror. I practice my headlines. I practice them with friends in the NICU. I practice them with friends out of the NICU. I practice them driving to work. I practice them walking around the elevator at work. Here are a few examples of a simple bit of medical information in blue paired with a meaning in green. They can feel really nuanced and challenging when multiple systems are involved. And if you're ever brainstorming a headline, just know I'm a resource. I'm always happy to brainstorm these. So a headline doesn't take much time in the room, but the prep work for it can take time. I also will say often when I'm teaching headlines, I'll find people who want like the perfect headline that's going to get whatever desired results they're looking for. And I'll say that sometimes I will feel I have a really good headline and it won't land right with a particular family. It is, I try and practice seeing those as learning moments where if it didn't land right with a family, that family needs something else. So I can, even in the room, say, I'd like to back up. I'd like to try that again and try something new and try to figure out what this family needs. It can be daunting, but helpful to try them with simulated patient experiences. And so I encourage communication training for everybody. Often I have people ask, oh no, I tried to communicate with a family and I did a horrible job because I made them mad or cry or freak out. I wonder if often that is a sign that we actually communicated really effectively. Sometimes if a family has a big emotional response, it means we communicated the headline well. So I don't always see big emotions as a sign that I did anything wrong as a provider, and I hope you all see that as well. Which brings us to the fourth step, which is responding to emotion. And the second key truth of communication, which is that we just can't process cognitive information when blocked by emotion. I think when we reflect on how we as human beings learn, when emotional, it's really hard to learn. And our patients and families are constantly in a learning space where they're needing to develop skills, process medical information, rework their identity as a parent. And it is really impossible to do that effectively as a parent if you're full in an emotion. So let's talk about some common frameworks to respond to emotion. Perhaps everyone in this room is already fantastic at it. I would not be surprised. I think that I am a fairly empathetic person, and I still like having this real steady scaffolding so that when emotions are high in a patient room, I can kind of stabilize myself thinking about some different categories of ways that I can respond to families. The NURSE acronym is my favorite. Each of the letters stands for a type of statement that responds to emotion. One are naming statements, like this must be really overwhelming. This must feel really hard. U is understand statements, which tend to be into I can't imagine statements or I can only imagine statements. R are respect statements. I use these a ton. I love them. These work better when you're authentic and when you can name specific things that you respect about a family. I can see you've been here at the bedside for days at a time. I can see when I'm watching you read to your baby how much you love your son. Support statements, the S is for support. These I think felt clunky in my voice the first few times I tried them, and I've really had to kind of work in the support space to feel the ones that work with me. But they're typically, we're going to be with you on this journey. Whatever the test results show, we'll be here to explain them to you. So they're typically statements like that. And then E statements are, can you tell me more? Can you tell me more about what's concerning you? When you use that word, could you tell me a little bit about what it means to you? Things like that. Each of these categories of responses, each of these ways to respond to emotion can help us as a family is moving through an emotion to get to a space where they're ready to process and take in more information. But of course, that if you're starting in a really elevated emotion, it's just impossible for one statement to bring you all the way down to a space where you're ready to learn. So when using nurse statements, it's really helpful to almost imagine the emotional roller coaster people are on, and to ask yourself where they are and if they really seem ready to get more information. So I often use many nurse statements to reach a place of talking about medical information more. And sometimes I even find it appropriate to do another ask, do the step 2 again, and ask if people are ready for more information once they seem more neutral. And that brings us to our last step, which is answering patient-guided questions. I think this step really varies in duration based on a family's bandwidth and what they're ready for. I find that these dialogues sometimes go a lot better with breaks in them. So when it's possible, I'll get through a little bit and then ask if people would like a break or for me to come back in some time. And my biggest tool and suggestion to everyone would be to let these be patient guided. Ask what they want to know. Ask what's important to them. And ask when to come back, like when would be good for them to come back. If I'm reaching what feels like a wall and a family that has no questions, I'll sometimes plant seeds of some families want to know this. Is that interesting to you? But if they stay flat, I don't go into that. I just accept that's where they are and potentially try coming back later. Again, when communication is hard, it's about trust. And we don't trust other human beings immediately. So if it takes longer to build that trust, that's okay. To be more effective at answering questions, I again encourage people to lose medical jargon as much as possible, unless the family's using it, and then you mirror. All of these tools, these 5 steps, will help communication be more efficient and quicker, and will help communication be more meaningful and hopefully make all of us love our jobs. But there are times where smooth communication is simply not fast. And that can just feel really frustrating. So when smooth communication is not fast, I kind of walk myself through 2 steps. And one is to try to slow myself down and to give myself a pep talk that it doesn't mean I'm a failure, and to give myself a pep talk that I've had times where it took more effort and time to build a connection. If my own internal pep talks aren't working, I am quick to lean to peer-to-peer support and to call colleagues. And many of you on this call are people I have called to help buoy me along. Which brings me to the second really important way to get through when communication is not going fast, which is that we just have to work as a team, both to support each other and also because sometimes our team members have heard or seen things differently than we did. They may have insight into a particular family that we don't have. And I really believe that we can lift each other up when we work as a team and value each contributions. When thinking about communication, it's a practice. I've had some people say to me, it's like doing reps. Like when we go in with families, we're just doing reps so that we can get better and use our communication muscles and skills in different ways. And practice can be fun in ways it can feel playful when you look at it that way. To emphasize, my number 1 takeaway for everyone is to lead with curiosity and to not waste time trying to guide people blindfolded. So spend time investing in that first step of assessing where a family's at. I heard something really interesting about curiosity today, which is that being curious and asking curious questions only works if we're genuine, and that at the end of the day, we're all human animals. And if a person asks you a question that sounds curious, but the intent is not genuine, we often know in our gut we can often feel that lack of authenticity. So if you are not in a curious space, it might be a moment to try to find a way to take a mindful moment, to give yourself a moment to regroup and get grounded before you can go into assess. And the second key takeaway that I honestly anticipate most of you are quite phenomenal at is to really respond to emotion live and to give our families grace that when they're having emotion, they simply are not going to be able to process cognitive information. We talked about a little bit about controlling controllables, and I alluded that we have to practice letting go of the rest. In terms of the things we do not have control over, I often want to fix things that I can't fix. A lot of life is unfixable. It is a practice to let go of many aspects of our job. And this is another space where peer-to-peer support can be really beneficial to help us do our work to show up well for our families. I tried to save some time for questions because I wonder if all of us working on different projects and spaces on family engagement, there may be common bumps or stumbling blocks that you encounter. So I'm really open to discussing those as a group and learning from each other. And I'm just kind of happy to be a part of this wonderful community. I know everyone here is a helper and wants to transform our communities. Okay, I'm going to pause there.
Thank you so much, Lori. Such clear and well-presented advice, in such an empathetic and inclusive way. I've heard versions of Lori's talk multiple times, and each time I learned something new. So thank you, Lori. Let's open it up for questions or comments. I'll get us started. I think for those of us that are participating in today's webinar, we are I would imagine we've self-selected ourselves as individuals who are kind of porous and empathetic and who are givers and helpers. And I just wonder if you can talk about how we can perhaps protect ourselves through this process. Now, what I mean by that is I'll give you a specific example. I was recently on service. This was probably a few months ago. This one particular mother was really excited to take her baby home. And I came in, of course, on a Monday when I had not been the attending that had been on the 2 weeks prior. Monday was the day that she was supposed to be discharged. And I came on and she had sort of failed the car seat challenge. There were a few other things. And so I was the one that had to tell her that today was not the discharge day. And I tried my best to use some of the tools that you mentioned. And it went horribly. Understandably, she was quite upset and emotional, and quite angry. And what I was not prepared for is the anger directed toward me. And, she didn't mean it to me directed toward me, but I was the one that was delivering the news. And it was really hard for me to not take it personally. Like cognitively, I knew, oh, this is not about me. This is her disappointment about not being able to take this baby home who'd been in the unit for months and months. And yet it was so hard for me to kind of bear the brunt of her very emotional response. And so I was wondering what your thoughts are on how we as providers can serve ourselves. Like, how do we get ourselves through that sort of acute period?
Oh, Susan, thank you so much for your vulnerability. My guess is that many people on this call have also faced the onslaught of a huge emotional dump. And I can even hear the balance of emotion and realism in your words, in that, like, you cognitively know it's not your fault they're not going home. The emotion isn't totally supposed to be landing on you. And then the emotional response of, the emotion was directed at me and it landed on me. So now what do I do? I'm going to put a document in the chat that is a 2-page document of mindfulness and gratitude practices that I put together for taking care of yourself, and then how to use peer support effectively when work is hard. I would say that it has humbled me that I have to do a lot of work to take care of myself. I think I wanted to be this really strong human being who could just like withstand so much and be in all these environments. But I just find I need to do a lot of self-care to do the work I want to. And I'm coming to accept that, which is great. I have both things that I do in the unit. So there are a couple of really short, I call them like minute vacations. It's like a mindful minute vacation that I'll do to reset myself at work. And 2 of them that I do, and no one can tell I'm doing it. So it's like you can be on rounds and be in a minute vacation regrouping. And then one of the ones I do is alternate nostril breathing. And certainly you've got to be in a safe solo space to do that one without people thinking you look insane. But that one is a really effective way if your emotions are high to help bring you down. So I use mindfulness techniques real time. I use peer support frequently for myself from colleagues both in the NICU and outside of the NICU. And then I also find what you just did, Susan, being vulnerable and normalizing that even those of us who want to be great communicators sometimes have really hard communication outcomes where we aren't happy with the result. I think I put that document in the chart, but honestly, I'm not very technologically savvy. So if that doesn't work for people, maybe let me know.
Works, it's perfect. I was able to download it.
Great.
Other questions, comments?
I think there could be some really interesting space for some of the controllable things like how we work together as teams. And if anyone is interested in that, I hope that there'll be space for us to discuss that further, because I really deeply believe highly effective teams are going to help us do more and get farther.
I'll ask another question. Some of the things that you're talking about, and even this resource that you have shared, I feel like there are generational differences in people's responses to this approach. I think for people of the younger generation, this feels really natural and normal in some ways, sort of what they would do in really any relationship to some extent. But certainly is not the social norm amongst some of our older providers. And just curious to know how you have thought about bridging that divide. I mean, I think our social norms in clinical practice have really changed.
Yeah,
I would say even over the last 10 years.
yeah.
And
That's a
so
really great
curious to
point.
know your experiences and any advice related to that.
That's a great question, Susan. I bet I spend more energy looking to talk about communication skills with people who want communication skills. And for people who perhaps have less interest in trying new skills, just letting go of that and accepting, I'm not going to be the person who changes someone who's practiced for 30 years a certain way. I find that by trying to show up with non-judgment, I recently had a fairly senior provider who I would think of someone who doesn't use any of these skills on a regular basis, have a challenging patient encounter, and who came to me to kind of process that. And I just kind of did like peer-to-peer listening to what it was like. And then at the very end, they were like, well, so what would you have done? Like, what would you have done differently? And I just like high-fived myself for creating that space, because it's not always easy. And we talked a little bit more. Am I convinced they're going to change their practice? I don't know, but I really have grown to let myself celebrate a seed planting as a win. and a little sprout as a win. So I think time. I think that I try to, I'm really trying to coach myself that all good things can take a lot of time.
I see here there's a few questions in the chat. Erin says, thank you so much, Lori. Can you speak a bit about the importance of structure of a pre-brief or for providers and teams when they enter the room or space to have critical, crucial conversations with families and patients?
Hi, Erin. Great to hear from you. And that's a great question. I'm wondering if you mean like a care conference space. And I think Tina Fisher has some exciting ideas, and I think Meg Turner has done some work on welcoming meetings as well.
I think, Lori, I'm thinking about just even entering a room to talk to a family about, say you're going in as a multidisciplinary team to talk about MRI results. Sometimes I think we all charge in there with an idea about how the conversation should go, and we end up overwhelming the family or missing an opportunity for the conversation to be more structured, more open, more curious, like you said.
Love. My own inner prep is probably the most important. I have a mantra that I'll say to myself, and I'll do 4 breaths doing an inner mantra, like saying one thing on the way in, one thing on the way out to try to ground myself. That's really helpful for me. When I pre-brief with a team, I am fairly intentional about trying to ask and make sure we're using the family's names. I think that names can really personalize and humanize some of the experience. And I think there are systems, there are almost like checklists of really quick ways that you can get ready before a patient encounter in terms of what you need to know. I'm happy to kind of share some of those, but they often include, does anyone on the team have an idea of what the family's expecting? Does anyone on the team want to share what they currently understand as the family's where they're at with this disease or process? Does anyone have anything important they think we should know about the family? And it tends to be kind of really trying to use the broader team to make sure that we don't have gaps, recognizing we aren't going to know everything before we go in.
We've got a question here from Igor. Lori, could you speak to a little how we deal with reflecting on conversations that may have gone well and felt supportive, but the healthcare outcome was poor for the patient or family? Is there such a thing as giving too much hope, even if the family seems to be looking for hope?
Igor, that's really good. I really see 2 questions in that, and probably a whole talk in and of itself. Betsy Bloom talks about the fact that if our families don't have hope, they can't have the strength to walk back in the room and deal with what it's like to have critically ill children. So there's one part of me that says hope is such a great, powerful thing, and certainly I have to end on hope. Is there too much hope? Yes. If you have blind hope where you're not pairing it with medical reality, that to me is where you kind of cross the line to too much hope. And so I'll often navigate that space by saying, man, I really want to hope with you. In the meantime, I'm going to be here for you, and I'm going to tell you what I see because I want you to know what I know. And I'll balance with statements like that, yep, you keep hoping, and I'm going to keep on telling you what I see. So I often pair like that and find that works. Interestingly, I recently had a very challenging care conference that ended with the family saying, it feels like you're giving up on my baby. And we kind of responded to some emotion there and emphasized that there were lots of right choices for families in their situation. And what was so interesting is I was a little worried at the end of that encounter that the family had no hope. But what was interesting was when I went and revisited them later that day, they actually, I think, really had come to trust our team and were then ready to have really hard decision-making conversations. So I also just want to emphasize that these are dialogues. This is not like we have an hour care conference and everything's getting done. If you finish your hour and it still feels rocky, you're going to go back in a couple more hours of the next day. So give yourself the grace to remember that this is a often longitudinal process.
And the last question here from Blair. Do you ever find that families advocate for this type of interaction after having one or more providers who have done so? For example, after your service block to families, do they feel empowered to lead conversations better? I just want to add, Blair, that in fact, that's a reality. When Lori Sherlock goes off service, the families are like, oh, there's this drop in enthusiasm. So it is a real thing. But Lori, I will help you. I will let you answer that question.
That's really funny. Well, sometimes I have started trying to coach families on how to ask questions of their team. And I actually think, Blair, this question is like, I personally would love to get into a lot of research on how to help families navigate this better, because you're right. We can't control who is the person on service. I was just at a presentation where some people with lived experience were saying the only solution is if we can have kind of dedicated attending quarterbacks for kids with chronic illness. Well, I think all of us in this space know that probably isn't realistic or feasible. So if we can't have one person who's a constant force in a child with critical illness, how do we empower the family to navigate this on their side and to bring questions or bring what they're advocating for to the medical team in a way that's easier? And I think we could do some really exciting work there. I do think that sometimes families, of course, we all appreciate when people listen to us and are trying to meet us when we are. So yes, there are families who prefer that type of communication. And it's my hope that it eventually will all be communicating that way, or at least the majority of us will.
Thank you. Well, Lori, that was great. Thank you so much. I think we all have learned so much from you these last several years. And if folks want to reach out directly to Lori, she can chat in her email. Lori, if you can do that, that would be great. Let Lori do that, and then wonderful. Okay, well, thank you everyone for your time. I hope you have a great rest of afternoon.